It's a pleasure to be here, to be asked to talk. Ian asked me just to say a little bit about pre-cancer. You're actually going to get much more information about pre-cancer from the patients, I'm sure, than me. We know actually surprisingly little about pre-cancer or potentially malignant lesions. We know a few things. We know that smoking and alcohol is bad for you. We now know in the new world that HPV is creating a new type of oral cancer. Across the world, just remember, it's one of the most common cancers that we have, and we know something, thanks to a lot of work in Asia, about some of the conditions that predispose to cancer, and this is betel chewing, which is a very common habit in Southeast Asia in particular. The trouble with pre-cancer, and one of the things that it needs a lot of research for, is it's not the sexy stuff that you've just been seeing some great surgeons producing their results. It's actually rather difficult to see and know that you've got pre-cancer, and that's one of the major difficulties. Here's a lip with pre-cancer, but most of you wouldn't actually recognize that as you saw it. And on the next slide, somebody who smokes who's got candida, again, pre-cancer or potentially malignant disease, but not something that you might necessarily associate with cancer. And here, this very vague whiteness inside a cheek, pre-cancer, but it might not be. It could just be cheek biting. How do we know the difference? Well, we don't. It's actually very difficult, even for very experienced clinicians sometimes, to distinguish between those. And then you've got the problem of this massive field change. And here's one example which is quite easy to see, but any bit of that might at any time become malignant, and our job is made incredibly difficult to survey these patients and know which bit is going to go malignant. Molecular biology is an area of research which may help us in the future, but it's not there yet. And if you look at this, for example, here you've got two bits of different pathology that are both caused by smoking. On the left-hand side, you've got the keratosis just from the heat of smoking, which is entirely innocent. But on the other side, you've got erythroleukoplakia, which is actually potentially malignant. Spotting the difference between the two, even for experienced clinicians, can be quite difficult. Now, there are various ways that have been tried and tested. I've been involved in this sort of stuff for many years. Others have. This is toluidine blue. But there are lots of other stains that are available to try and identify precancers at the early stage. The trouble is, none of them are very good. They're either not very specific or not very sensitive, or they're oversensitive. So it's a very difficult field indeed. All I'm going to say, and then I'm going to hand over, is that the answer to many of these questions lies in collaboration and cooperation, creating big data sets. And I'll just use a couple of examples of where big data sets can actually get you answers to questions very quickly. The obvious one is in joint replacements. The National Joint Registry in this country collects data on all joints and their outcomes, and as a consequence of that, they were able to identify without any costly, expensive and long-term clinical trials that a particular hip, the Dupuy hip, was actually failing. So that's the power of big data sets. The other one, of course, is cardiac surgery, where for cardiac surgery, mortality is actually useful. It's not useful for many other things in terms of measuring outcomes, but through that data set, they've contributed to improvement in the quality of care of cancer. So NFORC has the opportunity in the UK, and I hope across Europe, to actually start to collect big data sets so we can answer some of the very simple questions that sadly, even today, we don't have the answers to. So it's a very important initiative, and I'm very glad to see so many people have come here to support it today.
I'm going to talk to you about my research in translating science into the clinic on early cancer detection. And I'm a cell molecular biologist, and over 3 minutes I'm going to tell you why my research is important. So World Health Organization has predicted that there will be a dramatic increase in the cases of head and neck cancer by the year 2030. And importantly, the survival rate remains almost constant over the last half century. And we need to know why this is the case and do something about it. So why is it? And most patients turn up late with advanced tumor requiring major operation. And it's very expensive, debilitating, and require 10 days hospitalization at the minimum, poor morbidity and low survival rate. If we can detect it early, it's a simple surgery requiring no more than 20 minutes. It's a local anesthesia, low cost, no hospitalization, no morbidity, and a very high survival rate. And we've heard previously as well. So where is the problem? The problem is in pre-cancer detection. 90% of oral lesions are benign, and only small percentage, 10%, progress. There's no method that at the moment can identify these 10% of high-risk patients. Pathology grading cannot determine cancer risk. Because cancer is a genetic disease, we do need a genetic tool to tackle this problem. So our solution is to have a genetic test. So at the moment, patients with unknown oral lesions are put on watchful waiting. And this is a fantastic recipe for causing anxiety, stress, wasting time, burden on the NHS, and it's proven to be not have poor outcome. Our solution is to take a little bit of biopsy, extract genes, and measure the genetic changes and convert it into a measurable cancer risk so that we can identify these 10% of patients and treat them quickly, release the 90% of them without high risk, and reduce the anxiety, and hopefully we save time, money, and lives. So where are we at the moment? The genetic test is currently in progress. We have published our first clinical study involving samples from donated by patients from Ian Hutchison, thank you very much, and also from Norwegian. And currently we're testing samples from China. And this is the world's first head and neck cancer test at the moment. And there's no other organization similar to ours that has the capacity to do this type of research. So in summary, we aim to create non-invasive screening together with the early diagnostic tests in order to reduce uncertainty in patients and provide a better and faster treatment and overall improve patient outcome. I'd like to thank Saving Faces and the Wellcome Trust for funding this research. And we do need the NFORC data sets in order for us to trace patients' outcome and which will benefit.
Hi, my name's Sharon. I haven't got a script, I've got no presentation, I'm just going to tell you as it was. In December 2006, went to the dentist. He noticed something on my tongue. I hadn't noticed it, it wasn't painful. If he hadn't have drawn it to my attention, I probably wouldn't have noticed it at all. Put me on antibiotics for 10 days, then referred me on. I had the first biopsy as under local anaesthetic. They did the biopsy. It's not a pleasant procedure. Not one that I wanted to do again. 6 months later, it came back exactly the same spot, same colour, same size. I had to have one under general anaesthetic. That was pre-malignancy. Obviously, being under general was a bit more invasive for me. Exactly the same place, but I thought everything was fine. They said they'd taken a margin around from there as well, so it was definitely gone this time. By the following February, March 2008, I knew it was back, but I didn't go back to the consultant. I didn't want any more biopsies. I thought it was probably, there's me deciding for myself, it's probably pre-malignancy going nowhere. I fell pregnant in the March. By the July, August time, my husband decided, he booked an appointment for me to go see a consultant again. He said he had to make a phone call outside and rang the professor who was waiting for me that night. I went the next morning. I was operated on the next day. It was full-blown cancer, but in some ways maybe that was a blessing because you're waiting for it anyway. So, and at least this way I had a partial gastrectomy. So really they had taken a huge chunk out. Well, I thought it was huge. It was horrible. And my biggest thing was obviously I was 20 weeks pregnant, so I couldn't have neck dissection, which again is a positive. And touch wood, I've been fine since.
Good afternoon, my name's David Wood. I just clocked up my 78th year. In 2002, I underwent an operation through Guy's dental school for a roughness on the inside of my lower right jaw, which I thought had been brought on by my ill-fitting denture at the time. The operation was carried out. A small skin graft was taken from my thigh to cover the site, and a fortnight later, imagine my surprise when the surgeon said to me, unfortunately the biopsy has proven to be a squamous cell carcinoma. It was a bit of a bombshell. Cancer, a word which flashes through the mind. What do you do? It's the first time I've been in the hospital probably for 50 years, apart from breaking things when I go skiing. I asked him some questions, and I wasn't totally convinced with his answers, and I said I would like to get a second opinion. And we left that surgery with doubt, concern. Where do you get a second opinion? My GP said he didn't know anybody who specialised in mouth cancers. Not very helpful. Fortunately, my old dentist said, there's one person I would go to, and I won't name him because I think he's embarrassed. And he arranged an appointment 48 hours later, and I went to see that person. And his attitude was reassuring. It was something he'd obviously faced before. I wasn't the first person, and the care and attention was apparent. We then had an operation later in 2003 on the lower jaw, and then I had an operation on the upper jaw in 2003 as well. And since that time, I have had quite a few interventions as day patient, as each little white speck, those pictures we saw earlier on, seemed to cover my jaw area. Unfortunately, in 2007, my brother had cancer of his tongue. Again, he thought it was roughness, and the dentist filed away at his teeth to try and make them smooth, but it was only the registrar in his local hospital who happened to look at his tongue one day and said, "Can you hang on a moment?" And he was operated 3 days later for 2/3 of his tongue to be removed and chemotherapy. Unfortunately for my brother, it came back again after a couple of years, and he died nearly 3 years later. The interventions one has, I used to call it cut and slash, actually, have obviously changed the configuration of my jawline. There are no teeth, so I have a denture. But every time there's an intervention, it seems I've lost suction, and I then have to go and have my plate relined to try and give back some of the suction. This has been quite beneficial. In fact, I think I've got a better smile now than I had before all the surgical interventions, and I have to say thank you to Susan down there, who's been looking after me now for 12 years. The latest intervention was I had a spot on my palate, which was removed, and unfortunately the palate has collapsed, and I now have a hole there, and my denture needed to have a plug on the top surface so that it blocks the hole. Otherwise, liquids go into my mouth and come straight out of my nose. So again, thanks for the nearly watertight denture. That is my experience. I would say that it has been wonderful. having somebody one can go to, he really is a friend. I can contact him and ask questions. And I think for a lot of patients, this relationship between surgeon and them and the reassurance they can give is absolutely crucial, because believe you me, every time you go and have an intervention, you're waiting really for the answer to those biopsies when they come back. Is it clear, or is there more problems? Thank you very much.